great. Well, David, thanks for the invite, and thanks, John, for A, making half my case for me, but B, also really helping to kind of frame the question. You know, there have been over 200 publications on prognosis in myelofibrosis alone over the last several years. So I'm almost apologetic to our fellows that there has really been a proliferation of proliferative prognostic scoring systems that in addition to being a terrible alliteration, is both confusing and I think really needs to be taken in the context of what these data tell us. And at the moment, all the data really tell us are prognosis in terms of survival in myelofibrosis patients. But what they do not tell us is really any insight in terms of choice of medical therapy. I think we use them for decisions around stem cell transplantation, although they really haven't even been validated in that setting, in that largely patients with transplants still seem to stratify according to their prognostic score, so that the patients with lowest risk disease do the best with transplant, and those with highest risk disease do the worst. Now, particular with this topic, I'd qualify that JAK inhibitor therapy should be considered in symptomatic lower risk myelofibrosis patients, and that I think it is really the burden of disease for patients as opposed to their prognosis that drives choice of medical therapy. So we're going to focus really on 6 different points in the time that we have. The first is current indication and rationale of JAK inhibitor use to begin with. So ruxolitinib is our sole approved JAK inhibitor at the moment. There are others in development that we'll discuss in a moment. And it was approved on the basis of improvement in splenomegaly as well as symptoms. Now, the enrollment in these studies, the COMFORT-1 and COMFORT-2 study, were intermediate 2 and high-risk patients with myelofibrosis. However, the choice of that selection of intermediate 2 and high risk was arbitrary. Having been involved in the design of those studies, the phase 1 studies, which began in 2007, excluded patients with low and intermediate 1 risk before there was any safety data regarding JAK inhibitor therapy. So it was a accommodation, a discussion with the FDA that limited it. There was really no scientific basis for excluding these patients. There was really nothing to say that these patients may not respond. The formal indication in the US is ruxolitinib is indicated for intermediate and high-risk myelofibrosis. So there's not a substipulation in the US for intermediate 1 versus intermediate 2, with a caveat now being platelets over 50,000. So let's look at a case to illustrate a little bit of the difference between burden and prognostic score. 63 PV for 12 years, progressive fatigue, cachexia, loss of need for phlebotomy. Heavily symptomatic, MPN 10, 40 out of 100. Spleen is big. Hemoglobin is 11.8, not uncommon in post-PVMF. Leukocytes of 18, platelets 240, peripheral smear 2% myelocytes. Marrow 3+ reticulin fibrosis, karyotype 20q-. Post-PV myelofibrosis. Now, as we look at their burden, according to the DIPSS, their symptoms are the only one of the 5 criteria present. Now, this is the limitation of continuous variable cutoffs for prognosis. He's 63 versus 65. Does that matter? His hemoglobin is 11.8 versus 10. What if it had been 10.1? So again, they are helpful, but there are some real limits. I prefer to think of it a bit in terms of choice of medical therapy around the burden, broken up by symptoms, spleen, anemia, or evidence of progression toward AML. And here the individual has both splenomegaly and symptoms, which really fits quite well with the data we have regarding ruxolitinib. This individual received ruxolitinib 20 twice a day. We're monitoring counts, spleen, and symptoms, and indeed ended up having a very nice response to splenomegaly and symptoms and is doing quite well on the medication. Now, what about the burden of the disease? As I'm trying to allude through this talk, the burden of the disease is different than necessarily how long we live with the disease. There's risk of vascular events. They're probably greater in PV and ET, but they clearly can occur in MF, and if they do, they can have morbidity. The burden of cytopenias. The burden of the potential of progression. indeed where we are in our life's arc. I being in my mid-40s, if I had myelofibrosis, you can't give me a score that is good enough for me to really feel reassured that I have, good myelofibrosis. Indeed, in all of those subgroups are individuals that have worse disease. The burden of splenomegaly. Splenomegaly has not been vetted in any of these prognostic scores, not necessarily because the spleen size does not have an impact on the disease. It's really a limitation of retrospective analysis. If you dig up charts from 30 years ago, physicians were horrendous at documenting the size of the spleen. You look at charts and it says spleen big, spleen huge, spleen down to the pelvis. What does that mean? It is uninterpretable. So all of those retrospective analysis, all of that has to be thrown out the window because the spleen numbers were uninterpretable. Symptoms, 20 years ago, you're lucky if you got a blood pressure on a chart, let alone, a thoughtful documentation regarding symptoms. So are symptoms in there? Only the most extreme. So again, those scores are what they are. The symptom burden clearly is variable and important, as are the comorbidities. Third, an evolving understanding that even according to the prognostic scores, which John really nicely laid out, when we talk about low risk by which of these almost Byzantine interlocking set of prognostic scores are we really talking about? In terms of symptom burden, we did look at a large number of patients with myelofibrosis stratified by DAI-PSS in which we had symptom burden. And what we found is that there are low-risk patients that have significant symptom burden, but we also have higher-risk patients that don't have a lot of symptom burden. In the end, we have found that there's a decoupling between movement toward acute leukemia, which does not seem to have a lot of symptomatic burden associated with it, versus progression along the arc of myelofibrosis with big spleen and symptoms. So again, a patient might have a lot of risk without a lot of symptoms, and again, that may have other implications. It's been found as well that subtle differences in counts or other variables can have impact. This was presented at last year's ASH. A hemoglobin of between 10 to 12, they do worse. A platelet count of less than 150 but of 100, they do worse. Spleen size over 5 centimeters in this more modern subgroup, they do worse. Palpable hepatomegaly, they did worse. So again, further and further refinements in really what are different phenotypes of disease. An additional slide that Alessandro Vanucci showed at this year's ASH was applying the MIPSS, which is a complicated system. I think it's one that is it's probably the most helpful of them up to the moment, primarily for our transplanters, and really something that, like the IPSS-R, I think really needs its own website to calculate. I mean, they're really, I tell fellows, don't try memorizing these things. Memorize the observations behind them. Cytopenias are bad. Certain molecular features are bad, but trying to memorize how to calculate these things is a waste of time. But once they're applied, we see that we can substratify patients who by IPSS, low, intermediate 1, or intermediate 2, we could see that there really are very distinct populations within them. And clearly, I think the karyotypic piece is relevant as well if they have an abnormal karyotype that fits into that mix. 4, clearly the choice of using therapy in earlier risk patients is 1, a bit around efficacy, and 2, around safety, because the main reason they were excluded when we started was because of concern the drugs hadn't been tested yet in humans. Would they be safe? In terms of efficacy, the efficacy seems to be durable. This was the 3-year follow-up data from ruxolitinib with consistent benefit in terms of splenomegaly. And other analysis that I don't have on the slides here, it was seen from the COMFORT studies that individuals, if we treated them earlier in the arc of their disease in terms of the size of their spleen, they probably did even better than those who we were treating who really had very advanced disease. In a lot of ways, that's logical, as most of our therapies are probably most impactful if we don't use them at the extremes. We see 3 years, Patients have persistent improvement in symptom burden. We have seen improvements in survival in both Comfort 1 and Comfort 2 that carry out to 3 and 3.5 years. This is the survival curve from Comfort 2 versus best alternative therapy. And there is data suggesting that particularly in patients on for a long period of time, of which we all have now patients in our practices that are on 2-3 years that have done really well, there are some individuals that seem to have improvement or stabilization of myelofibrosis. 5, we are seeing now the activity and benefit of JAK inhibitors in earlier MPNs, let's say advanced PV, problematic PV, and this is very relevant as we start thinking about earlier patients with MF and that this group clearly overlaps. In terms of intermediate 1 risk MF, this is a UK study in which they presented interim results of the robust study at 24 weeks and showed, let's see here in intermediate 1, good activity in terms of spleen size, symptoms, individual symptoms, responses just as favorable in the intermediate 1 risk patients as those with intermediate 2 or high risk. So there really was no lack of benefit in this group of individuals. Additionally, there was presented at ASH a compilation from US-based hematologists with a large number of individuals who were low risk or intermediate 1, and it was stratifying them or judging them by the severity of splenomegaly in those in which were being treated with ruxolitinib. And we're seeing, even in intermediate 1 risk patients, the severe burden of splenomegaly in this group, and even in the low risk in the vast majority. And again, a bit of the reflection that significant splenomegaly is not directly in one of the prognostic scores. Finally, ruxolitinib now approved in polycythemia vera, and I think this has relevance of interest, at least in early myelofibrosis. Compared to best alternative therapy in problematic PV, ruxolitinib was superior for control of hematocrit, splenomegaly, symptoms, and potentially less thrombotic events. And then finally, there's a robust pipeline of approaches really looking at this lower risk group of patients, which continue to really make us interested in trying to impact that disease course. Indeed, if we look at patients with myelofibrosis, let's say they are on a JAK inhibitor and they have decrease in splenomegaly, symptoms, improvement in survival, they have an improvement in clinical status. Perhaps we might have greater benefit or more durable benefit if that is earlier in their care arc. Goals in terms of new agents or future combinations include further decreasing fibrosis, cytopenias, or improving molecular response, or increasing duration of response. There are multiple ongoing studies in myelofibrosis, both single agent and in combination. And several of these include clearly patients with intermediate 1 risk disease that have problematic features, including the studies which have been ongoing with pacritinib and momelotinib. So as I look at early myelofibrosis, these patients are not all the same. From my end, I'm looking at early myelofibrosis patients potentially benefiting from therapy, not only JAK inhibition therapy, if they really have evidence of burden of the disease. Do they have mild anemia? Do they have symptom burden? Do they have splenomegaly? Do they have evidence of progression? Clinical trials are ongoing for this group and include other agents as well, including the interferons as well as the other JAK inhibitors, pacritinib and momelotinib. So I'll leave you with this proposed algorithm, which is how I try to follow these patients. After they are diagnosed or they visit with me, I look at their risk. I think their risk is an important consideration, although it impacts me the most regarding choice of transplantation. I assess their symptom burden. Low-risk patients who have no symptoms, this is a group where I may consider observation. This is a group which we do have a trial which is beginning with low-dose interferon. Low risk but symptomatic. It is here where I think a discussion of JAK inhibitors is very relevant and appropriate, depending upon the symptoms, depending upon how problematic. those symptoms are, as well as their other features. Those that are intermediate to high risk, the first decision is regarding transplantation, urgent, delayed, or never. In urgent, we'll move to that in the next several months, but there are ongoing trials through the MPD Research Consortium and others looking at JAK inhibitor therapy first. Delayed JAK inhibitor therapy, clearly the standard of care. Those that have a suboptimal response or lose response, it is there where we look at our clinical trials. I'd like to very much thank my group in Arizona for all of their assistance with these efforts. Thank you.